Now we'll turn to the nursing perspective, which is equally vital in ensuring continuity of care and patient engagement in the management of growth hormone deficiency. I'm delighted to welcome our next speaker, Anne Marland from the UK. She is a consultant nurse, advanced practitioner at the Oxford Centre for Diabetes, Endocrinology and Metabolism in the UK, part of the Oxford University Trust Hospital. Anne is the lead of a large team of nurses and associates who focus on advanced clinical practice, education, research, and leadership. Her presentation is titled The Role of the Nurse, Growth Hormone Deficiency, will highlight the contribution of nurses across the patient journey, from diagnosis to long-term support. And thank you for joining us. The floor is yours.
Thank you, Valentina, and thank you to Dr. Haberbosch for that very insightful presentation. I would like to thank the organising committee for inviting me today to present the nurse's perspective on growth hormone deficiency. So I would just like to say that I do not have any conflicts of interest. So I'm delighted to present to you the nursing perspective of growth hormone deficiency. This will be focused on adult patients. So the presentation will cover the nurse's role in diagnosis, treatment, and ongoing care. And importantly, I would like to introduce to those of you who have not seen the competency framework, which has recently been published in its 3rd edition from the Society for Endocrinology in the United Kingdom. And we will review the competency framework and particularly focusing on the 9th competency, which is adult growth hormone deficiency, which is one of the competencies out of 18 competencies. So importantly, the nurse's role is still very involved in the diagnosis. And we have heard very clearly about the diagnostic steps we can take to actually ascertain that an adult is growth hormone deficient. So the nurse's role, we can play a very crucial part in this by taking the patient history and also the recording of the clinical measurements. So in the United Kingdom, we have very strict guidance, which comes from the National Institute of Clinical Excellence. And we follow a very specific document for growth hormone deficiency in adults. And these are adults who are above the age of 18. So within the National Institute of Clinical Excellence guidelines, we have to follow specific diagnosis. And this will be that the diagnostic test will only be after the stabilization of all the other treatments that possibly the patient is on. And we will wait for 3 months until the patient is stable and all the medications and the biochemical recordings are within the parameters of normalization. We will then consider testing and providing a diagnosis of growth hormone deficiency. And this will also be recorded along with other clinical parameters. So we will be looking at past medical history. We will look at the number of pituitary hormone deficiencies. We will also be looking at if there was any previous growth hormone treatment in childhood or through transition in adolescence. And we will also be looking at quality of life which has already been alluded to, we follow the AGDA measurement. So this is a evidence-based questionnaire. And part of the diagnosis of growth hormone deficiency, so even to a diagnostic test, which we have just heard about before, so that could be the insulin tolerance test, could be Marland, a glucagon test. We will ensure that the AGDA score is at least 11 or above, i.e. indicating that the patient has an impaired quality of life. So from a nursing perspective as well, we will also look at country-specific shared care. So in the United Kingdom, a lot of us within England will have to apply to our GP colleagues in primary care to ask them whether they will enter into a shared care for growth hormone treatment in adults. This is really because we have the National Health Service, where our medications are very tightly controlled, and where we have to justify the expense of a medication. So that is very much part of the diagnostic nurse's role within the United Kingdom, is being aware of that shared care. And I'm very aware that in the other countries, and some of you attending here, you will have very different policy. And so please just follow and be aware of your country policy on funding for growth hormone treatment in adults. So another important part of the nurse's role is educating our patients about the actual diagnostic procedure and then the subsequent pathway of treatment. And also alleviating their expectations of the timeline from the beginning of the process to actually receiving treatment. So the education around the diagnostic procedures is, as a nurse, becoming very knowledgeable about what's actually involved in an insulin tolerance test and the side effects, what is involved in a Marland test, and again, side effects. And again, empowering our patients to ensure that they are well educated and therefore will pass through the test without any undue anxiety. So I also say about the expectations of timeline. So in the United Kingdom, it is possible occasionally to have to wait 3 to 4 months from where the patient first presents in clinic and the consideration of growth hormone has been made to them actually receiving their first injection. But as I have said, this is very much to do with funding and to do with the commissioning procedure, and also our colleagues willing to enter into the shared care process. So nurses obviously play a very key role in treatment. So treatment, this is providing the education on the actual self-administration of the injections. Now, in England, we tend to use the daily injection, and as yet, a lot of the long-acting formulations have not yet been approved. So we're using them in pediatrics, but not in many centres for adult use. And again, this is to do with commissioning and with our shared care. So I'm going to focus this more on the daily injections. So the daily injections of somatropin, which, as we've heard, can come in many different forms, and you will be aware of the different pharmaceutical companies that make various different formulations of somatropin. So these are a self-injection and they are subcutaneous. So part of our role is to educate the patient in a correct subcutaneous injection. It is also our role to discuss the options and the devices. So in an ideal world, we would like to give patient choice. However, in recent years, commissioning tends to lean more onto the side of preparations that may be slightly cheaper. So therefore, lots of centres maybe will have 1 or 2 first-line options and then 3rd or 4th line options if there is any question about the patient's compliance or whether they potentially have any visual impairment, cognitive impairment, or dexterity, where one may find that a particular device would be more applicable to the patient's needs and requirements. So part of the treatment as well is to monitor the patient response to the growth hormone replacement. And this includes advising on adverse effects and also empowering our patients to report these effects and give them a direct line of communication where they can actually have answers from an expert. So many centres in the United Kingdom, we would have advice lines where the nurses are very well educated in growth hormone deficiency. In fact, many centres will run growth hormone-led nurse clinics, and therefore the patient has a direct contact in terms of their endocrine specialist nurse. So part of the treatment as well is the biochemical monitoring, and this will be in terms of measuring the IGF-1, which we have just heard about. So this is the insulin growth-like factor 1. And as we have learnt, growth hormone itself is pulsatile, and so we can't actually measure a random growth hormone. And also because the patient has been diagnosed as being growth hormone deficient, the way of actually ascertaining the level of treatment is by measuring the IGF-1. Now, here in Oxford, when a patient first commences on treatment, they would come to my clinic and I would measure the IGF-1 once a month. But that is also because I'm within the constraints of the National Institute of Clinical Excellence guidance, which stipulates that when a patient starts treatment, they can receive that treatment for 9 months. And as long as at the end of that 9 months, their IGF-1 reaches the mid-upper range of normal, and the IGF-1 is age match depending on your age. So we know that physiologically you would produce more growth hormone when you're younger. So the IGF-1 assays will actually follow a patient's, they will mirror a patient's age. So therefore our rough cutoffs are 40 to 60, you'll be in the mid-range IGF-1 assays, and then 60 plus, the IGF-1 will actually, the assay will, the levels will actually reduce to match the normal physiological growth hormone that that patient, if they were producing growth hormone, would be producing. So part of my treatment as well is to look at that quality of life questionnaire, which is the AGDA. And so through that 9 months of treatment, I will be asking the patient to repeat the questionnaire. And of course, it's very important when we're taking this kind of information from a patient that we try not to bias those answers, and that we give them a comfortable space to fill out the questionnaire, and possibly not with their relative looking at their answers. And those of you that are not familiar with the AGDA, I really recommend you just having a look at that. So it's questions out of 25 questions where the patient will answer yes or no. And we hypothesize that with growth hormone treatment, the patient will improve their score, and the patient should improve their score by at least 7 points at 9 months. And that's part of the NICE stipulation. And actually, one of the main reasons why you would discontinue treatment at 9 months if their quality of life had not improved. However, very careful monitoring of the treatment is vital to give the patient the best possible outcome. Hence, to be seen monthly initially, and then possibly every 2 to 3 months until you get to the 9 month. So another part of treatment is managing side effects and adjusting the doses if you're a non-medical prescriber. Many of us in England, the UK, are non-medical prescribers. And if you're not a prescriber, then liaising with the prescriber. Side effects. The most common side effects in adults are arthralgia and myalgia. And again, it's educating our patients to understand what those things mean and how to actually manage that. So if I had a patient who said to me they had sore fingers and they had slight swelling and it was bilaterally, then we have various options as nurses and prescribers where we could reduce the dose. And one of the important things to remember with growth hormone replacement, it is a protein, it is circulating, and it will take a couple of weeks if you do a dose reduction or a dose increase for you to actually achieve that circulating level of growth hormone replacement. So going on to the ongoing care. So as I've alluded to, these patients require regular follow-up, especially at the beginning of treatment. You follow your country-specific guidelines. The ongoing care is to always be the go-to person for your patient to come to address their concerns, any questions they may have. And then our role as nurses as well is to coordinate and communicate with other healthcare professionals. So in the UK, we're also fortunate that we can utilise third-party care providers. And these are providers who provide complementary care to the NHS, basically to support our services in rare disease. And we can utilise these third-party care providers for delivery of medication to a patient's home, to deliver supplies, so needles, to carefully remove sharp spins, because as you're probably all aware, we have very strict health and safety around the disposal of sharps. And then it's also our role as well to monitor that the patient is fulfilling any of those shared care agreements that you have gone into agreement with as a secondary or tertiary care provider with the primary care provider, which would be the general practitioner. So the doctor out in the community where the patient is living. So our role is also to promote adherence to our treatment plans. And of course, we know as nurses that to empower our patients, education is key. So that delivery of the information you give to your patient at the beginning of their treatment can really make all the difference into how the patient fulfills what we wish them to follow, i.e. daily injections every day, 7 days a week, and to be feeling better about themselves, to be able to cope with the injections, and to actually, as I've said, give them that best possible opportunity to feel better by the 9-month period. So let's now talk a little bit about the Society for Endocrinology Competency Framework for Adult Endocrine Nursing. So hopefully a lot of you are aware of the Society for Endocrinology, which is the leading organisation in the United Kingdom. We are on the 3rd edition of the Competency Framework, and this is rolled out across Europe, and we've translated the Competency Framework into many languages. So I'm really hopeful that a lot of you have seen this and you're aware of it. So this slide just shows where we just presented recently at the British Endocrine Society meeting. So the competency framework, it's on the 3rd edition. It has 18 competencies for endocrine nurses at all different levels to follow. It aligns with the 4 levels of advanced practice, which is education, leadership, management, research, and then obviously the clinical parameters. It provides an evidence guide and also has a whole source of resources which is linked to each competency. So the 9th competency is growth hormone deficiency in adults. And I thought it would be very useful for us to actually have a look actually at, well, we're going to look at the competent level and the expert level. And so this is just a shot of the competent level of growth hormone deficiency. Now, the competency framework you can also access online, and this is on a platform called Cooper. And once you're on the Society for Endocrinology website, you can actually access through onto Cooper, which is just the name of the platform. And the idea is that it's a living, working document for us as nurses to actually be able to match where we believe our competency is. So we start at novice and we go through to expert. So we have novice, we have advanced beginner, and you can, this is also applicable for those in your nursing team that are not qualified nurses. So in the UK, we have care support workers, and we also have associate practitioners, assistant practitioners, and nursing associates, which would be more at the band 4 level. And so we have aligned the competency framework to suit all within our teams. So this is an example of the competent level. So as you can see, let me just go to, there we go. So competent level steps. So you would be moving on from the advanced beginner and then becoming more competent. So you can see that it's split into 10 sections. And so this is a really good way of us all looking and ascertaining where our learning needs are and where we can work with our colleagues, our medical colleagues and our other nursing colleagues as to how we can actually improve our knowledge and also identify our gaps in knowledge. So as you can see, a competent nurse would have knowledge, understanding of anatomy, physiology, pathophysiology of the hypothalamic pituitary axis, knowledge and understanding of the disorders relating to growth hormone deficiency, the knowledge and understanding of the investigations to diagnose. So that is good knowledge of massamarelin, insulin tolerance test, glucagon, etc., whatever is pertinent to your country specific. Understanding policy, understanding commissioning requirements in your country. And then as you can see, we move through and we're looking at patient focus. What are the key knowledge and skills to actually manage these patients safely? Looking at emotional, psychological impacts of growth hormone deficiency. Being able to identify non-adherence, and is either that through your discussion with your patient, is it looking at the biochemical results, and actually where you can, you know, see that potentially the patient is not taking their growth hormone regularly because the IGF-1 is dropping, etc. So now I'm going to just move on to the expert level steps. So as you can see, you would have reached proficiency and then you will move through to the expert level. So in the UK, an expert would be a practitioner or a consultant nurse. So someone who has started to really develop those 4 pillars of advanced practice in nursing. So you're probably going to be a prescriber at this point. And you'd be running your own clinic. And you could potentially be taking your patient through from, say, the pituitary clinic and taking them through the whole diagnosis. You could be ordering the diagnostic tests. You could be actually analysing those results, and then you could be implementing the treatment plans. But taking your patient all the way through, which from a nursing perspective is a very fulfilling pathway to actually take a patient through a whole treatment plan and come through to the other end, and hopefully your patient will be responding very well because you've given them really expert care and a lot of nursing input. So just to have a quick look at the growth hormone dose and administration. So the most common starting dose is around 0.2 milligrams per day. This is an evening subcutaneous injection. So evening, because if we go back to Dr. Haberdash's presentation, if you remember the slide where we saw the peak of growth hormone, this is in an evening and overnight. So what we're trying to do is physiologically match that peak of growth hormone. Hence, you will always ask your patient to inject in an evening. Over the first 2 to 3 months, we'll adjust the dosage, and this is looking at side effects in consideration of any side effects the patient might be having, and also looking at the IGF-1. So if your IGF-1 is starting to rise within the range, and your patient is not experiencing any side effects, you will just gradually titrate the dose. However, if your patient was experiencing some side effects, you may decide to keep the dosing at the same level and then reassess in another 4 to 6 weeks, where hopefully those initial side effects are settling. So our current maintenance dose in the average sort of middle-aged adult would be around 0.4 milligrams per day. And obviously this will vary individually with different patients. And as I've also mentioned, the requirements will decrease with age, and this is mirroring the physiological natural production of growth hormone. So just coming towards the end of my presentation. So in conclusion, nurses are essential in the management of growth hormone deficiency, and this is encompassing diagnosis, treatment, and the ongoing care. The competency framework facilitates effective learning, reflection, and progression, and also importantly, always ensuring safe care. And effective nursing improves patient outcomes, promotes safe and effective monitoring of growth hormone therapy, and facilitates improvement in patients' quality of life and reduction in comorbidity risk factors. So thank you very much, and I'm hoping that we can have discussion in the Q&A. I'm very aware that each country probably, from a nursing perspective, you have different involvement at different aspects of the patient's care. And so thank you very much.